Hi, let's talk about the pulmonary plexuses. In this video, we'll discuss the basic structure of the autonomic innervation of thoracic viscera with a special emphasis on the pulmonary plexuses. So there are three major visceral targets of autonomics, each with their own devoted set of plexuses within the thorax. There are the cardiac plexuses that are going to serve the heart and coronary vasculature. There are the pulmonary plexuses, which are going to serve the bronchial trees as well as the pulmonary vasculature, which will be the focus of this video. And then there's also the esophageal plexus, which we'll discuss with the posterior mediastinum. Now, all of these plexuses are going to have exquisitely robust series of communications between and among them. So none of these are existing purely in a vacuum. Many of the fibers are interwoven between these plexuses. There is tremendous amounts of interplexus communication. It's important that we discuss them and that you understand their locations in theory, because within the laboratory, as you clean off the investing fascia of organs and other viscera and vasculature, you're going to remove much of these plexuses. So it's important that you understand where they are, so as you're removing them, you can appreciate them. Now, autonomic plexuses will have a variety of innervation sources. So generally, there are both sympathetic and parasympathetic innervations to an autonomic plexus. The thoracic viscera are going to receive their innervation from the sympathetic side from both the cervical and thoracic regions of the sympathetic chains. Now recall that the pathways for sympathetics involve both a pre and a post-ganglionic series of fibers. And the pre-ganglionic series of fibers which serve the thorax predominantly arise from the spinal cord at spinal nerve levels T1 through T5. Sometimes there may be fibers from T6, but the dominant outflow via those white rami communicantes, which we can see there, are from levels T1 through T5. So those go out to the sympathetic trunk, and keep in mind those white rami communicantes are only found between the T1 and L2 levels of the spine, whereas the sympathetic trunk or chain is found from the base of the skull all the way down to the coccyx at the ganglion impar. So the inflow might be thoracolumbar, but the sympathetic chain runs throughout. And this is a good example where we have an inflow from T1 to T5, but fibers can ascend all the way up to the superior cervical ganglion of the cervical sympathetic trunk, and then exit and travel inferiorly to the thorax. And so we'll see how the various levels of the cervical and thoracic ganglia are going to serve the pulmonary plexuses. It's also worth noting that with respect to the pulmonary plexus, typically the fibers are coming from the T2 through T6, as well as the cervical ganglia, but all of these fibers will come back along through that same pathway when we have the visceral afferent fibers that conduct the pain pathways. And so referred pain will typically refer to dermatomes covered by those spinal nerve levels. Now, the other constituent to the autonomic plexus will be the parasympathetic, And the vagus nerves, cranial nerve 10, are the dominant parasympathetic supplier to everything from the neck through the thorax, through the fore and the midgut. And so we'll see how branches of the vagus nerves and branches of branches from the vagus nerves will participate in these autonomic plexuses. Now recall that there are visceral afferents associated with both the sympathetic and the parasympathetic, and whereas the visceral afferents associated with the sympathetic are the visceral pain pathways, the visceral afferents with the parasympathetic are for feedback and for reflex fibers. Now let's focus on the thoracic outflow. So T1 through T5 levels are going to be the white rami communicatis out. So those are the pre-ganglionics. And coming off of the sympathetic trunk, we're going to see cardiac branches from the superior cervical ganglion, from the middle cervical ganglion, and from the inferior cervical ganglion, as well as direct branches from the second thoracic through at least the fifth and sometimes the sixth thoracic ganglion of the sympathetic trunk. So those will all be branches coming directly from the sympathetic trunk out to the pulmonary plexuses. There are the same branches, also inclusive of T1, that are supplying the cardiac plexuses. And it's important to understand that a lot of these fibers are the same. So they are traveling in and amongst these two plexuses, and they're serving a similar function in terms of a sympathetic response, as we'll see. Now from the vagus nerve, high in the neck, there are going to be branches that arise directly from each right and left vagus nerve called the superior cardiac branches. Sometimes they're called the cervical cardiac branches. And these are going to leave early, and they're going to intermix with some of those cardiac branches from the superior cervical ganglion as they descend down within and adjacent to the carotid sheath towards the thorax. There are also going to be inferior cardiac branches, which are also going to descend down as they originate within the carotid sheath into the thorax. Now, with the vagus, there are two major nerve branches that are going to arise from the vagus, and they do so in an asymmetric fashion. So on the right side, there is a right recurrent laryngeal nerve that wraps around the subclavian artery in the root of the neck before it ascends superiorly to serve the larynx. On the left side, the left vagus nerve makes it down to about the level of the arch of the aorta before the left recurrent laryngeal nerve wraps around that concavity and ascends in that tracheoesophageal groove on the way up to serve the larynx. And both of these recurrent laryngeal nerves are going to send branches to the cardiac and pulmonary plexuses, as well as the esophageal plexus. And then the vagus nerves after are going to continue their descent distally along the esophagus. They move posterior to the roots of the lungs, which we can see here and here. And that's going to be important because those pulmonary plexuses are going to be straddling the roots of the lungs, as we'll see. And once the vagus nerves make it posterior to the roots of the lungs, they form a very close association with the esophagus. The left vagus nerve is going to assume more of an anterior orientation. The right vagus nerve assumes more of a posterior orientation. And that they will then be known as the vagal trunks. Now, the vagal trunks aren't exclusively left versus right. There are some fibers of each nerve in each trunk, but predominantly the left vagus nerve, most of its fibers become the anterior vagal trunk. The right vagus nerve, most of its fibers become the posterior vagal trunk. And we can remember this by the mnemonic LARP. Left anterior, right posterior. Now, before the trunks come into existence, those vagus nerves which have already supplied cardiac branches high within the neck will also send more branches to the cardiac plexuses. They'll also serve dedicated bronchial branches to the pulmonary plexuses, as well as various esophageal branches, as we'll see. So the pulmonary plexuses are very difficult to differentiate from the deep cardiac plexus, and they're going to enjoy fibers from both cardiac plexuses. So recall that the superficial cardiac plexus is found in the concavity of the aorta. The deep cardiac plexus is found nestled between the bifurcation of the trachea and the arch of the aorta. And the pulmonary plexuses are going to be found straddling the roots of the lungs and will be both anterior and posterior to those roots of the lung. And so we'll have continuity between the cardiac plexuses and the pulmonary plexuses, such that it would be nearly impossible from a gross perspective, even with the most perfect dissection, to decide if a fiber was of the pulmonary plexus or of the cardiac, or of a cardiac plexus. Now, there are two types of pulmonary plexuses. There are anterior plexuses and posterior plexuses. The anterior plexuses are very small. They account for possibly about 25% of the total innervation of the pulmonary plexus. They're absolutely contiguous with that superficial cardiac plexus, so all of the inputs for that plexus are going to be the same inputs for those anterior plexuses. So we're talking about the cardiac branches of the superior cervical ganglia, as well as the superior cervical cardiac branches of the vagus nerve. In terms of the posterior plexuses, which are about 3/4 or 75% of the innervation of the pulmonary plexuses in total, all of the same innervations for the deep plexus, which involve the cardiac branches of the cervical ganglia, as well all cervical ganglia, so superior, middle, and inferior. The cardiac branches of thoracic ganglia T1 through T5 from the sympathetic trunk. And then from the vagus nerve, there will be cardiac branches. There will be branches from the recurrent laryngeal nerves, and then there will be dedicated bronchial branches from each vagus nerve to those plexuses. Now let's think about what the pulmonary plexuses will do. From a sympathetic standpoint, the sympathetic stimulus will lead to bronchodilation, so we'll have a relaxation of the smooth muscle that is going to line the airway, so a greater ability to move air. There's also going to be vasoconstriction of the pulmonary arteries. So much of a sympathetic response will lead to vasoconstriction. The only exception that we have now as an example will be that the coronary arteries vasodilate during a sympathetic response. Parasympathetic responses are going to include bronchoconstriction, and it's not that the airways narrow that much, it's just more of a maintenance of the tone of the smooth muscle tissue that comprises the airway. There will also be increased bronchial mucus production, as well as vasodilation of the pulmonary arteries. When we think about an autonomic response with respect to the lungs, however, typically we think of rates of respiration. And so in terms of a sympathetic response, respiration rates will increase. In terms of a parasympathetic response, respiration rates will decrease. But those aren't being modulated by the pulmonary plexuses. Those are being conducted by the phrenic nerves under the control of the brainstem, the medulla and the pons. So we've discussed the various autonomic plexuses of the thorax with our focus on the pulmonary plexuses and their locations, their particular inputs, as well as the individual sympathetic and parasympathetic responses. This is your summary slide. Thank you for your time.